Good afternoon, everyone. So now Dr. Banu has presented two cases. So we have seen the differential diagnosis also. So it's mainly liver diseases complicating the pregnancy. So now next few minutes we are going to discuss about the how to diagnose and management of the liver diseases complicating the pregnancy. So if you come to the liver diseases in pregnancy, it can be classified diseases per se related to the pregnancy and liver diseases which are unrelated to the pregnancy also. When come to our both cases, so these two cases we are ruled out those diseases unrelated to the pregnancy. So in this session we are going to discuss only about the pregnancy related liver disease, because our two cases, our main DDs are acute fatty liver of pregnancy, HELP syndrome, severe preeclampsia and cholestasis of pregnancy. So how we can differentiate these conditions? Because AFLP, HELP or severe preeclampsia, if you see the clinical features, most of the clinical features are overlapping. Even some of the laboratory findings are also overlapping between especially AFLP, HELP and preeclampsia. So it is very, very difficult to diagnose a single entity based on the clinical features alone. And depending upon the investigations, we can have a diagnosis, most probable diagnosis only we can say. If you want a definitive diagnosis, most of the times we will require a liver biopsy, which we won't do routinely. So if you see the clinical features, like generalized features like pain abdomen, generalized malaise, vomiting, nausea will be there in almost all the conditions. The only clinical features which are specific to obstetric cholestasis is the pruritus, which we may not see in the other three conditions. If the patient is having pruritus, especially it will start in the palms and soles, then it will become generalized. So those symptoms are very specific to cholestasis. The other symptoms are similar in all the three conditions like AFLP, HELP and severe preeclampsia. So other signs and symptoms and laboratory symptoms which are specific to AFLP are ascites is usually present in AFLP, hypoglycemias, and the level of rise of aminotransferases which are there in AFLP are around 5 to 10 times the normal. So these are specific for AFLP. If you come to the HELP, so they can have hypertension and proteinuria in 85% of the patients, and the ascites is very rare but still can be there in some of the patients, like less than 10% of the people only they can have ascites. The level of LDH rise is very high in HELP when compared to the other conditions. So usually in HELP there will be the rise of LDH will be more than 600 units per liter, and even enzyme elevation also it will be up to 100 times it can be there in HELP when compared to AFLP. If you see preeclampsia, so coming to the symptoms in preeclampsia, they'll have a more neurological symptoms when compared to the other conditions. The symptoms like headache, blurring of vision, even seizures can be there in a severe preeclampsia when compared to the other conditions. So here the prominent features will be they can have mild AKI, but the other symptoms like hypoglycemias, hemolysis will be very rare. But thrombocytopenia can be there in preeclampsia. So if you see all the features, there is overlapping of features in all the conditions, and it is very, very difficult to diagnose a single entity based on this. So that is why we have a certain criteria to diagnose these conditions to have a high index of suspicion for the diagnosis. Like Dr. Banu said, there is a Swansea criteria for diagnosing the AFLP, and we can have a Tennessee criteria or Mississippi criteria for diagnosing the HELP. So Swansea criteria, there are around 14 parameters are there, including clinical, laboratory, and even histological diagnosis also. So amongst 14, if 6 or more are present, means there is high probability of diagnosing the AFLP. We can diagnose early AFLP based on the Swansea criteria, because early diagnosis and treatment is key for reducing the morbidity and mortality in a mother and child. So the sensitivity, if you see the sensitivity and specificity of the Swansea criteria, it is 100% sensitive, but the specificity of Swansea criteria is very less. It is around only 60 to 70%. And if you see the predictive value, the positive predictive value of criteria is only about 80%. But if you see the negative predictive value, it's 100%. So if you have the criteria, it is 6 or more, we can say it is probably AFLP. But if the criteria is not meeting, we can definitely say AFLP is very, very less likely, because the negative predictive value is 100%, but the positive predictive value is only 85%. So if you see that 14 features whichever there in the Swansea criteria, almost 5-6 factors are common for HELP also. That is why most of the times the AFLP, HELP or severe preeclampsia, it is very, very difficult to differentiate, and most of the times they can coexist also. So that is why based on this we can have a probable diagnosis, and then the treatment is almost similar for all the 3 conditions. So what are all the complications we can expect in a liver diseases complicating pregnancy? Because the management for AFLP, HELP or severe preeclampsia is almost the similar, and the ultimate or final treatment will be the delivery of the baby. So what are all the complications we can expect, like hypoglycemias, acute renal failure, sepsis, they can have encephalopathy, coagulopathy, disseminated intravascular coagulation, bleeding, even ultimately they can land up with the fulminant hepatic failure, especially AFLP patients. So management, it needs a multidisciplinary approach including critical care physicians, obstetricians, hepatologists or medical gastroenterologists and neonatologists. So it comes under maternal stabilization and delivery. So maternal stabilization and delivery will go hand in hand, because while stabilizing the patient we have to plan for the delivery, because the ultimate treatment or is the delivery of the baby. Once you deliver the baby, most of the symptoms will come down. Until you do the delivery, it is very, very difficult to control the symptoms, and stabilization of the mother is also very, very difficult. So the stabilization and delivery will go hand in hand. While stabilizing the patient itself, we have to plan for the delivery, because these patients usually will have a coagulopathy, low platelet count, and they will be in dehydration. So we have to do stabilization at the same time the plan for the delivery. So initial management includes airway, breathing, circulation. So we have to maintain the patient's airway, breathing, and along with circulation also. These patients mostly they will have a intravascular dehydration. So we have to have a proper hemodynamic monitoring for fluid management. So we have to maintain the euvolemia. While giving the fluids, we have to be very careful, because these patients, they'll have a very less oncotic pressure. So if you overload them, they are more prone to have a pulmonary edema. So we have to give fluid management very carefully, and we have to try to maintain the euvolemia by doing a proper hemodynamic monitoring. At the same time, these people, they'll have thrombocytopenia and coagulopathy. So while planning for the delivery, we have to correct the coagulation abnormalities and thrombocytopenia. So it includes prompt delivery of the fetus. Coming to the mode of delivery, which mode of delivery to choose, whether vaginal delivery or cesarean section. So it depends on the maternal and fetal factors. Depending on that, we can plan either vaginal delivery or cesarean section. But whichever is the mode of delivery, we have to keep our coagulation factors ready, because our target is we have to maintain platelets at least 50,000, and we have to maintain INR of around 1.5 before going for the delivery by giving the platelets and FFPs. Otherwise, the chances of bleeding will be very, very high. Even the risk of bleeding will be very high in cesarean section when compared to the normal delivery, but most of the times it may not be possible to go ahead with the vaginal delivery, because in these conditions the mothers are in a very unstable condition, so vaginal delivery may not be possible, though the bleeding risk is very less. So almost in literature also 65% of the times when the patients are in liver diseases complicating pregnancy, they'll end up with cesarean section only. The bleeding risk is very, very high. We have to alert the blood bank before going for delivery. We have to order, and we have to keep ready all the blood and blood products like PRBCs, platelets, FFPs. Sometimes they may need cryo also. So all those things we have to keep ready before going for the delivery. And if the patient is hypotension, even with the after fluid resuscitation, the blood pressures are not coming up, we may need to start vasopressors to maintain the mean arterial blood pressure. And if necessary, if the patients are going into pulmonary edema, or if the patients are having any respiratory distress, they might require mechanical ventilation, and we have to continue even after the delivery also, depending on the condition of the patient. And these patients, especially AFLP patients, they are more prone for hypoglycemias. Even sometimes in severe preeclampsia and HELP also, they can have hypoglycemia. So we have to monitor the patient regularly for development of hypoglycemia. If necessary, we have to give continuous dextrose infusions for correcting the hypoglycemic episodes. And these patients will have coagulopathy. As I said, they might require multiple transfusions. So usually our practice is to do a point of care testing like thromboelastogram, which will gives us the actual functionality of the coagulation system. Based on that, we can plan our blood products. So it says us that which products to give, where exactly is the defect in the coagulation system, it will tell us. So that the amount of utility of the blood products will be reduced by using the thromboelastogram. So in our hospital, routinely we will practice using the thromboelastogram for giving the blood and blood products, especially if the patient is having bleeding manifestations or if the patients are having coagulopathies. Then comes the renal replacement therapy. These patients usually they'll have acute renal injury and they'll go into metabolic acidosis also. If you see both the cases, they have a metabolic acidosis. Even if there is acute renal failure and with the involvement of liver, they can have a lactic acidosis and severe metabolic acidosis also. So if the patients are having these severe metabolic acidosis, or if they are going into oliguria or anuria, they might require continuous renal replacement therapies. So in these patients, when do we refer these patients to a tertiary care center? Because these patients are likely to go into fulminant hepatic failure. So before that itself, we have to shift the patient to a tertiary care unit, because early treatment and early interventions, we can prevent the morbidity and mortality. So if the patients are having coagulopathy is not recovering, they are going into severe coagulopathy, it's always better to shift the patient to the tertiary care centers. And coming to the advanced therapies, when the patients are going into acute liver failure, because most of the AFLP patients, they can go into acute liver failure. Even HELP patients also, they can have hepatic hematomas, subcapsular hematomas, they can have hepatic infarction, and ultimately sometimes they can have hepatic rupture, or sometimes they can go into acute liver failure. If the patients are having acute liver failure, the adjunctive therapies include, we can give N-acetylcysteine infusions. Next comes the plasmapheresis. If the patients are having coagulopathy, or if they are developing encephalopathy, coagulopathy is refractory to our correction of coagulation factors, we can offer them the plasma therapy or plasma exchange. So in most of the studies, it has shown that plasma therapy, if you are offering plasma therapy to a patient, those who are going into acute liver failure, we can prevent them going into a liver transplant. But we have to offer the liver transplant to the patient. Meanwhile, while preparing the patient for the liver transplant, we can do a plasmapheresis and other liver supportive therapies like MARS also we can try in patients, those who are going into liver failure. Ultimately, if they are not recovering, they are having severe signs of liver failure, we have to offer them the option of liver transplant. So the take-home messages, we have to maintain the high index of suspicion of AFLP, because the early management is very, very important. So early recognition and prompt delivery are crucial for improving the outcomes. So the management is primarily the supportive only, focusing on organ support and treating the complications. So a multidisciplinary approach is needed, and we have to be very vigilant in identifying the complications and treating, such as sepsis, disseminated intravascular coagulation, and cerebral edema. We have to always consider AFLP in the differential diagnosis of severe liver dysfunction in pregnancy, even though if the initial presentation suggests more common conditions like preeclampsia or HELP. Because AFLP remains a challenging condition in critical care, but the outcomes have improved significantly with advances in the supportive care and increased awareness. If you see, the mortality rate in AFLP in previous days is around 85%, but now with the advances in the treatment, the mortality has come down to almost as low as 4% to 25%. So the mortality in AFLP nowadays, it is only 4 to 25%, previously which is around 85%. So that is why early diagnosis and early treatment is very, very important in AFLP patients. Thank you.